where the experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, good morning, everyone, and welcome to the show. I'm your host, Vic Senese, and you're watching UroNurse. Glad you could join us today. Hey, if this is your first time joining, or maybe you haven't liked and subscribed to the show, be sure to do that. You're driving our algorithm so more people will find us. So today, our guest is Dr. Steve Goldberg, a chief medical officer at the HealthTrackRx. Dr. Goldberg is a board-certified physician and healthcare executive with an MBA who has spent his career advancing preventative medicine and personalized healthcare. At HealthTrack, he helps lead innovative approaches that use technology and health data to empower patients and improve outcomes. Today, he'll share how these advances are changing the way we think about prevention, wellness, and the future of healthcare. Please join me in welcoming Dr. Stephen Goldberg. Welcome to the show, Steve. How are you doing?
Good to be with you, Vic, and good to be with your audience.
Yeah, glad to have you on board. So we're always glad to have new information, and I think urine testing and things like that are, the cusp of what we want to learn about, and who isn't interested in things that kind of connect with AI too. So I'm going to bring up your slides and let you take it away, and we'll come back for questions after you're done.
Well, great, thank you, and good morning, everyone. So I serve as Chief Medical Officer of HealthTrack. We're the nation's leading in outpatient infectious disease testing. We have a strategic relationship with UPS that allows us to provide results the next day. And doing that enables clinicians to know exactly what's going on with patients and make sure the treatment is specific for what's going on. So we like to know, not to guess. And I'm excited today to talk about next day molecular testing and how it impacts diagnostics and decision-making. We're going to be focusing on urology cases and particular testing. Here are some objectives for today. So by the end of this discussion, we'll understand how impactful and frequent urinary tract infections are. We'll talk about the different types of diagnostic testing, including molecular testing, and we'll actually apply what we know to a particular case. We always find that fun. Why do women get urinary tract infections? They're much more common in women than men. About 50 to 60% of adult women have a UTI, their first one by 24. And it is a trigger for about 8 million encounters to the ambulatory setting. That can include urgent care, women's health, family medicine, internal medicine. And the direct costs of bladder infections or cystitis is over $1 billion a year. So it's a very impactful problem, and having good diagnostics is critical. Now, the evidence says that for most people who have a first episode of an uncomplicated urinary tract infection, clinicians can empirically treat them, and there are several antibiotic options. So women's report that I have a UTI is actually very accurate for finding bacteria and bacterial pathogens in the urine. Our focus really today is around those that have recurrent and complicated infections and how molecular testing can help get that treatment right. One of the reasons we want to think about ever specific and sensitive testing is because of resistant trends in antibiotics. We're aware that antibiotics are overused. In fact, antibiotic-resistant infections will be the leading cause of death worldwide by 2050. It causes well over 20,000 deaths in the United States of people getting infections for which there's not an antibiotic. And that applies also to urinary tract infections, and commonly for several different types of bacteria we see listed here. And what's concerning is that traditional antibiotics are often resistant in an individual person. So rates of resistance can be 25% for trimethoprim sulfamethoxazole, 21% for fluoroquinolines, and 4% for nitrofurantoin. So getting the diagnosis right and the treatment right is especially critical in this age of resistance. The Infectious Disease Society of America in 2025 helped us better identify, characterize, and engage women who have resistant or complicated urinary tract infections. And as you see, there's a revised classification on what constitutes a complicated UTI. And basically, it involves infection beyond the bladder, including the kidneys, if someone gets generalized fever or bacteria, if it's catheter associated, or in men, if they have prostatitis. Those are folks who are sick and for whom getting a very specific diagnosis and a right treatment is especially critical. And that's a profile where there's good support for molecular testing. Recurrent UTIs are something different, yet there's overlap. Greater than 3 UTIs within 12 months or greater than 2 UTIs in 6 months meets the definition of recurrent UTIs. And about 14 to 25% of women will develop recurrent UTIs in their lifetime. And what's interesting, there's 2 age bands of distribution, women 18 to 27 and women greater than 78. So the message is, for those of us taking care of patients, recurrent UTIs can occur in a broad age spectrum. Pyelonephritis is when you have infection in the actual body of the kidney. And in the past, pyelonephritis usually required inpatient treatment. But the IDSA has revised guidelines, and there are certain profiles of patients that can be managed as an outpatient. So that's why for those patients who meet that criteria to be safely managed in an outpatient, getting the diagnosis right and the treatment right is critical. And these are those that don't have severe illness. They are able to tolerate oral medications, and they don't have other complicated factors. And the concern when thinking about treatment for these folks is particular rates of resistance, particularly around fluoroquinolines. So one has to consider that before choosing an antibiotic. And then to the right are suggested general treatment regimens. For molecular testing, we want to really target it to those for whom it is a meaningful, elevated diagnostic test. And those profiles are really 2, those with recurrent UTIs and those with pyelonephritis. And there are particular profiles, as mentioned, of folks that fit into those buckets. So recurrent UTI, folks that are diabetic, immunocompromised, they're on oral contraceptive medicines, they're postmenopausal, or also they have some urologic anatomical change. Those with risk for pyelonephritis include those that have diabetes, a recent UTI, have frequent sexual encounters, have urinary incontinence because of a physiologic or mechanical issue, and finally, spermicide use. So those are profiles that we should be thinking about molecular testing to get the diagnosis right and enable us to get the treatment right. The current landscape we're all really familiar with in terms of diagnosing UTI. I practice primary and urgent care medicine and make use of certainly urine dipstick and urine culture and molecular testing in my private university practice. So what you see here are comparisons in terms of turnaround time, sensitivity, specificity, advantages, and limitations. The advantages of urine dipstick certainly are that you get an immediate initial perspective on what might be going on with a patient. The limitation is that its accuracy is somewhat limited. Urine culture is the gold standard because you get both pathogens identified and you can also identify phenotypic resistance. So resistance of that particular organism to antibiotics. That's different than genotypic resistance, which is something that is an insight generated from molecular testing. And finally, molecular testing. And our company is able to offer the test results the next morning. Many companies offer molecular testing, but being able to offer it the next morning is able to get an insight into a clinician's hands that can confirm the preliminary treatment or allow them to adjust the preliminary treatment. And there are certain advantages of molecular testing and cautions that we need to think about that we'll talk about in just a minute. Now, going back to urinalysis, no single dipstick finding means somebody has a UTI. No two means someone that has a UTI. But there are certain characteristic relationships of finding. So the finding of leukocytes often identifies white blood cells. The finding of nitrites often identifies certain type of bacteria, such as E. coli. But if you have one or two findings, that is supportive that the patient has a urinary tract infection following the right history of the patient, and that can inform initial treatment decisions. So let's talk about molecular testing. Oh, pardon me. Before we talk about molecular testing, one other blocking and tackling about urine culture and sensitivity. This is the process for collecting and resulting out a urine sample. And it is very detailed and it is very automated. Many years ago, you would simply look at a plate and little discs of antibiotic and see where the bacteria was killed. And that's how you made initial decisions. Now it is all automated with mass spectrometry, and you get both two key bits of information. One, what bacteria is there, what possible fungi is there, and then next, the antibiotic sensitivity to that particular organism. And you can get your sensitivity results in a low, moderate, and high. So sometimes you might have limited choices, but if there's high resistance, then you likely need to look for another antibiotic choice. And it's often written out as an R or as an S, S being sensitive, R being resistant, and sensitive with different levels of sensitivity. Now let's talk about molecular testing. Molecular testing is a technology that can be found in a number of different settings. It can be found in the point of care. It can be found in a reference lab setting. And there are different types of tests. The one I can speak to today is the one that our company makes use of, which is a PCR, preliminary chain reaction, and a nucleic acid amplification test. So basically, what happens is the nucleic acid in the organism is multiplied until you get the ability to determine whether there is a pathogen present or not. And the equipment that we have is a process where that nucleic acid is multiplied. What does RT-PCR mean? It's reverse transcriptase polymerase chain reaction. Basically, there's a process of reading the nucleic acid, and that's how you have an initial step to making multiple copies of it. Now, if you look to the right and the graph, this is an important concept, especially when considering events such as COVID. Oftentimes, you can be clinically ill and get tested. And then oftentimes you're recovering, but you'll have a positive test result. And that's because nucleic acid is still present. So one of the limitations and one of the considerations you have to make is when the person gets tested relative to their symptoms, and then given the nature of the illness, how that impacts your care planning for the patient. This is the basic process for testing. What happens is someone comes into an office and says, I feel ill. And in our discussion today, we're talking about a urine sample. So folks will generate a urine sample. You need a very modest amount because then you're going to be able to multiply whatever organism or organisms is in there. You take the swab, you then put it in a preservative. What that does is kill any pathogenic organisms, but preserves the nucleic acid. Then you come to the lab or to the machine in the office. You do an extraction of the nucleic acid. And then in the lab, you then proceed to do an amplification of that nucleic acid. And as the amount goes up, it is linked to a light signal. And so the more nucleic acid, the brighter the light. And that's how you ultimately get a reading and make a statement of the volume of pathogen in the sample. We'll talk more about these technologies should questions come up at the end. But what I want to talk about now is patient selection for molecular testing. Not every person, not every female that has a UTI needs molecular testing. As we saw at the beginning, the evidence shows that women are pretty clear to say, to have high accuracy that when they say they have a urinary tract infection, they actually have a urinary tract infection. And so empiric antibiotic treatment with consideration of antibiotic resistance is the standard of care in most environments for folks that do not have complications and are not having recurrent UTI. Molecular testing is generally positioned for folks who have recurrent urinary tract infections or complicated urinary tract infections. And there are a couple key advantages, including rapid diagnosis, because someone likely is ill. You can understand the antibiotic resistance in that particular person. Sometimes cultures that are taken aren't able to grow out an organism, but the high sensitivity of molecular testing allows you to generate a result with just a little bit of nucleic acid information. Well, the testing is also a component of overall stewardship. I mentioned at the beginning, a main problem that we have is overprescribing of antibiotics for infectious disease complaints. So using molecular testing appropriately selected, and for UTI, selecting it for folks that have recurrent or complicated UTIs helps us be stewards of both antibiotics and diagnostic testing. And many organizations are also leveraging this in companion to telehealth patient care models. Clinicians, I know we like to put things into a context that helps it stick. So we find that case studies really work. And let's come to a conclusion on today's talk with a case study. A 60-year-old female presents to an urgent care center with dysuria, discomfort with urinating, and increased frequency for 4 days. She denies vaginitis symptoms. She reports having a history of recurrent UTIs and having received antibiotic treatments in the past. She's got no history of a sexually transmitted infection, and she is active with one new partner. So, a couple things we see here. She's gotten antibiotic treatments. She's had a history of recurrent UTIs. That is a good profile for someone who would benefit from an insight from molecular testing. On clinical exam, her vital signs are all stable. So we don't see her as someone with a high fever. She clinically is not giving complaint of costovertebral tenderness, suggesting maybe pyelonephritis. So this is likely not a complicated urinary tract infection. She refuses a speculum exam, which would be relevant to consider given that she has a new partner and wanting to check that her bladder symptoms are not linked to a sexually transmitted infection. She undergoes diagnostic testing with the first technique that's available in the ambulatory setting, urine dipstick. It results out some findings, and then a PCR sample is collected and then sent. So we've got a few different things to consider in this patient for our differential urinary tract infection, pyelonephritis. She potentially has antibiotic resistance given previous treatments. And so what we decide to do is presumptively treat her with Bactrim. We'll assume that the resistance to Bactrim, which can be, we saw over 20%, is not as high in this particular community, making it a reasonable choice. And then we get the results back. E. coli greater than 10,000 colony-forming unit equivalence is found. There's a scale linking PCR to colony-forming units that is often used. And interestingly, Trichomonas vaginalis was also detected. So the patient also has a sexually transmitted infection. And so what we could do with the patient is discuss that she has both a UTI and Trichomonas and offer her targeted treatment for both organisms. So in summary, what we hopefully can see is that molecular testing has a place in the evaluation of patients with urinary tract complaints. It really seems best positioned for those that have recurrent or complicated urinary tract infections. One of the extra advantages of it is that it can be, for molecular testing, a way to identify organisms from both urinary tract and also sexually transmitted infections, as was in this case. And then in terms of the age profiles, we talked about there's 2 age intervals where this testing is likely appropriate. Now, as you're out there and in your practice and incorporating this testing into your work, a couple considerations. The payer landscape continues to evolve with regard to reimbursement. And I want to bring that out because we're all concerned about patients' exposure to out-of-pocket expense. What's clear, and what I see in my practice and in interacting with ambulatory leaders throughout the country, there's broad interest in this testing among ambulatory practitioners. There are several companies that are doing ongoing research and payer engagement activities. Right now, there is not an FDA-approved molecular urology testing platform. There are multiple high-quality lab-developed test platforms for urinary tract infection. There are several payers that identify coverage for molecular testing in certain populations, such as complicated UTI or recurrent UTI, but the payment, even if there's coverage there, might not be in place. There's general cost concerns about the cost of molecular testing versus a urine culture, which is generally well under $25. But in my experience, contemporary molecular testing is usually well under and certainly not exceeding $150, regardless of the pathogen count or resistance insights. There's opportunity certainly for future research to look at the long-term data of the higher expense, but not exorbitant expense, higher expense for molecular testing. But given certain patient profiles, such as those with recurrent UTI or those with complicated UTI, getting the diagnosis right and the treatment right, given the consequence of getting it wrong, is likely of great clinical and financial value. Common payer assessments that we see is this testing can be found to be investigational, and payers often have certain preferences, and sometimes not for the ambulatory setting, but for having this testing be available to specialists. So in sum, I hope that's an insight about molecular testing and its particular application to urology and urology diagnostics. I'll turn it back to Vic and be available for your questions. Vic?
Yeah, that was great. I really appreciate your presentation. I thought you gave us a good, concise kind of approximation of what's going on there. Let's kind of go back to the real case scenario where you had that woman come into your office. So she comes in at 3 p.m. with all that. We decide to send out to your lab the urine culture. So when would I really kind of be able to expect the results to come back to my desk?
Well, for us, what our testing can offer is molecular testing. And we offer that. Our commitment is the next day. We have high volume, well over 80% of folks that are getting it the next morning. So what a clinician could do is make an empiric decision about what's going on and then have our results the next day. So what would happen in this patient is a clinician could have started with Bactrim and then got our results showing that the Bactrim was a good choice, and then also that they had trichomonas and needed, for example, metronidazole as well. And that could have all gotten done, most cases by the morning, and the patient gotten the treatment right and not gotten sicker.
Yeah, that's a big change. I mean, we're used to urine culture as being a 3-day wait minimum, and trying to get enough urine for a proper sample. You're saying 1 cc is all you need for molecular testing. Is that correct?
That's correct. And then one thing I'll add, we're continuing to evolve with the marketplace. So we now have the capacity to do urine culture. That has not been a previous activity for us, but for, frankly, our commercial payers who are generally supportive of this testing for patients that were appropriately selected, we offer the molecular testing. And then for our members, for example, our Medicare patients for whom molecular testing is not supported, we have a urine culture option.
Gotcha. A standard urine culture that would be covered.
Yes, with the sophisticated contemporary equipment.
And as a practitioner, if I wanted to get this into my office, what would I go about doing to just call your company, or how would I have kits available?
Yeah, just go to HealthTrack, our website, present an inquiry, and you'll get a prompt call from our commercial organization.
Great. I'm going to go to some questions here. Let's see here. All right. So what are the most common infectious diseases your laboratory tests for? Which infections are becoming more concerning in today's healthcare environment?
Yes. So what I would say is that we test for different syndromes. That's how we organize it. So there's a respiratory syndrome, a gastrointestinal syndrome, a urinary tract syndrome, an STI syndrome. So we have groups of pathogens, bacteria, fungi, can be parasites, that are been selected for each one of our syndromes. And we're regularly consulting with elite infectious disease experts on what list of pathogens should be on each of our syndromes. And there are also some that we've taken off because they're present as part of, if you will, normal flora, and they're not indicated to be treated. And so if they're there and found, sometimes clinicians feel necessary to treat. But for urinary tract, we have well over 10 bacterial pathogens, 3 fungal pathogens, and then approximately 10 genotypic resistance genes that we're looking for.
Yeah. You brought out a good point about talking about that. Sometimes there's normal bacteria that's found in the bladder. Going back to when I first started practice, people thought, the urine was sterile. And we now know with the microbiome discovery that there are pathogens there is in bacteria found that belongs in your bladder. So you can't really sterilize everything, and you don't want to treat it. So.
Exactly. That's exactly right. And that's why with empiric treatment, there's good correlation between women who are saying, I have these symptoms. And that's why you don't, in people without risks, people who are not pregnant, go ahead and empirically treat simply based on a urine sample finding. You want someone to verbalize that they're having dysuria, frequency, burning, blood in the urine, because that supports that what's there is pathogenic.
Yeah, absolutely. Now I got this question for you. Do you see AI playing a role in infectious disease diagnostics? And where do you think it will have its greatest impact over the next 5 to 10 years? I love AI, so I'm always curious where this falls in.
Yeah, I'll share how I see it happening now. I see it happening now, and it is in use now, checking people's past history of urinary tract infections and whether they had a bacteria identified, yes, no, whether it was resistant, yes, no, and what antibiotic they were put on. And so you have that information that is incorporated into a results report, and that can make your treatment decision even more accurate. That's a first level. Then there's lots of other things, including looking at resistance patterns and other. It's an exciting time, but that first line is in place right now.
Yeah. Wow. All right. Let's see. I do have one from a patient here. For patients watching today, what should they know about when to ask their healthcare provider about infectious disease testing? Are there symptoms or situations that should never be ignored?
Yeah, it's a great question. So at HealthTrack, we're very careful to make sure our testing is used thoughtfully, judiciously. And so if you're someone who has never had a urinary tract infection and you have no medical complications, you can get your complaints well addressed simply by a telephone call to a telehealth provider and empiric prescribing, and you're likely going to do well. Our testing is really for someone who, for example, has had recurrent urinary tract infections, recurrent antibiotic treatments, urine culture samples that did not identify a pathogen, complicated medical histories. And that's where getting a very precise diagnosis and the right treatment is especially critical. That's the profile of patients that really do well with our testing. So if you're someone like that and you go into see your clinician, ask them about HealthTrack. And then if they're not familiar, just go to the website and reach out and we'll follow up with you.
Great. That's a perfect example is, we get patients that'll come in with this long history of recurrent urinary tract infections. You run a standard test and you really don't pick up anything showing up on the urine culture. And then you can run this DNA test and you'll pick something up that the urine test did not pick up, the standard culture. And this is a patient who's really happy, especially if they respond to treatment. They're obviously much happier if they do. But, people start, what am I, just crazy? They're telling me my urine's okay, but I don't feel okay. And we know there's other diseases that can have similar symptoms like overactive bladder, but there are some people out there that are harboring infections that they don't even know about that with treatment could be better. Have you seen that with your lab? Have you had any?
Absolutely. And I talk with clinicians who call me to discuss further the test results. And the stories like you're describing are ones that are especially satisfying. So folks that have come back and back and back to their clinician, just not feeling well, and then a
Yeah.
test is ordered, and then an insight's identified, and then they feel better. That's really satisfying for those of us at our company.
Another area that we see a lot of concern about is in the male population. I know we were talking about female urinary tract infections, but males get with this chronic prostatitis. Is it chronic prostatitis? Is it pelvic pain syndrome? And sometimes we've sent off actually semen off for culture. Is there any that being done for PCR, or is it looking at it in the future?
It is done, and for many men, it can be very, very helpful. We're aware that chronic prostatitis is a very broad problem, and oftentimes urine culture won't identify any pathogen. So using molecular testing can be very helpful for individuals with that presentation. The challenge is that the coverage is limited and the reimbursement is limited. So if one is having that, and you can talk with your clinician about access to this type of testing on a cash pay basis, but with the development of the testing, the actual cost of it is much more modest than it's been in the past.
Yeah. And I think for some patients, knowing is worth, you said the out of pocket could be around $150 if they were paying for the whole thing, correct?
Yes, and that's regardless of what syndromes you're testing for in a day and
Right.
how many pathogens you're looking for. It's gotten to be very, very efficient.
I mean, I have an idea what sometimes patients will come in with all these homeopathic medicines they've tried. And I'll ask them, what'd you spend on that? Well, I was $75 for this one and, $100 for this one, but it really supposed to work. People are throwing money away when there's probably things that they could be better investing in. So the fact it's not always covered isn't always a good reason not to get the test.
Yeah, that's something, Vic, that we think about a lot. Our organization has expert input from world-leading infectious disease experts. We interact with thought leaders in urgent care, women's health, family medicine, and pediatrics. We continually educate clinicians about the specific profiles that we think our testing can best serve. And yet, and also we're concerned about cost to patients. But for us, at least, we do have cash pay options, and they're very, very reasonable.
Yeah. Great. So I'm going to go over to a little promo for next week's show. And if you have any final notes or final thoughts you want to share with the audience when we come back, we'll do that as soon as we come back from this.
For how biological age testing, artificial intelligence, and precision medicine are revolutionizing the future of preventive healthcare. UroNurse is hosted by Vic Senese and features longevity medicine expert Gregory Brzezinski, MD. Dr. Brzezinski explains how understanding the biology of aging can help identify disease risk earlier, personalize treatment, and improve long-term health outcomes. The conversation also explores how AI-driven early disease detection is transforming modern medicine. Join us on August 8th at 9 a.m. Central Time to learn more.
Yeah, I'm looking forward to that discussion too. Like I said, I've been pretty fascinated with what AI can do, and I think it's going to really have a lot of different uses in the future for medicine, from reading, simple X-rays to pathology, etc. So, any final thoughts for us?
Vic, thank you. What I would say is molecular testing can be really helpful for patients suffering with urinary tract infections. There's a particular profile that we're really helpful for. Those with recurrent infections or those with complicated infections and complicated medical problems. That's where I would most think about health tract testing. We result it out the next day, majority the next morning, so clinicians can start an approach and confirm they're on the right one. So that's my message for today.
That's a great message. That's what we've been looking for, but we haven't had. I mean, for a simple urine test that you can dipstick and get an answer, that's okay. But when you have more complicated, having something that you can have on your desk the next day is great. So we appreciate spending some time with us today, explaining all about HealthTrackRx, and look forward to maybe another meeting down in the future about what's going on with your program. Thanks
Thank
for
you,
being
Vic.
on.
So here